Good evening. Thanks for coming. Recognize some faces here. It's good to see some people. I'd like to talk about hip replacement. It's one of my favorite subjects. And we do a lot of hip replacement here. We do a lot of knee replacement here. The way I thought I'd address this is talk about the questions I hear most commonly when people come into the office and ask me on a daily basis of what we do, how we do it, those types of things. So I'll start by saying why we do it. And it's similar to the knee. The main reason we replace hips is that they wear out. People get arthritis and the joint becomes stiff, painful, sore. A lot of people are, when they come in, feel like they have a muscle pull or a strain in their hip. They're surprised when we tell them that they have arthritis in their hip and concerned about it, but it's very common. And we don't fully understand why it happens, and some people will get it in one hip and not the other, and I don't have a good explanation for that, and none of us do yet. Someday we will. But the cartilage wears out, the bone starts rubbing on the bone just like in the knee, and it's painful. And it gets to a point where it's like having a bad tooth. You need it pulled. It's just not going to get better, and that's when you have it replaced. What is a hip replacement? It's a complete replacement of the ball of the hip and a resurfacing of the socket. So we use a number of components to do that. There's a stem that goes down the thigh bone, which has a neck on it, and it goes through a sleeve, and that attaches to a ball which connects to the socket, and the socket has a liner. It's modular. There's multiple components. We have all shapes and sizes. We can fit everyone from the most round to the most straight, so that it fits beautifully in the hip and recreates as much of the normal hip motion and hip function can be expected. There's a lot of concerns on television, the internet, everywhere about recalls and problems with hip replacement, and it's hard to escape that, especially in the demographic we have here in the audience. That's who they're after. The reality is that the problems affect a very small percentage of hip replacements. And I don't know of any that have affected patients who've had surgery done at Greenwich Hospital. But there's certain types of components where there's been some issues, certain brands. But the material that we use on a day in, day out basis is sort of tried and true. It's not experimental, and our patients have had no major issues with any of these types of components. Why should I get my hip replaced? It makes you feel better, and the NIH summarized that in this nice slide that they put together. I went on their website just to see what people were looking at about hip replacement. I figured the NIH was fairly neutral. And these are things that you can expect when you have your hip replaced. The beauty of hip replacement as compared to knee replacement is all this comes back quicker than when we replace your knee. That's a slower process and a little more painful for folks, but everyone gets to the same point with a knee or a hip. The hip people get there quicker. So it decreases pain and improves function and mobility, makes activities of daily living and function much better, improve quality of life, and for a lot of people that directly correlates in the ability to exercise and keep healthy in other ways. And that helps answer the question of when should I have it done? And with hip replacement, in general, there's no reason to wait too long. If it's really affecting the quality of your life, it's really affecting your ability to exercise, it's time to get it fixed because the fix isn't as difficult as it used to be. You'll hear about the way we do it here, but no matter where you have it done, you get better quickly now, and within a couple weeks, the vast majority of patients are glad that they've gone through the procedure. I see folks back in the office in 2 weeks, and it's amazing the difference. You can already see it in their face, the way that they feel about their hip. How do we do it? Similar to the knee, we use techniques that are best for the patients. And the techniques involve these minimally invasive concepts where we cut as little healthy tissue as possible. In the hip, there's some nice planes we can utilize between muscles where we can spread the muscles as opposed to cut them. Historically, we weren't able to do that, but some pioneers in surgery developed these techniques with these specialized retractors to move things around, hold them out of the way, and really minimize the damage to the normal, healthy, normal tissue around the hip. And why do we do that? It's better for the patients. There's a quicker recovery. Obviously, we're disrupting less tissue. There's less bleeding. The scar is smaller. That's important for some, not others. I tell patients their scars are generally correspond to their size. If you cannot replace a hip through 4 or 5 centimeter incision if it's a 5 or 6 centimeters down into the hip joint. So everyone's hips are shaped a little differently, and the scar is somewhat proportional to the depth of the hip. This benefits patients. This makes it less painful. You recover quicker. Function's improved, and obviously cosmesis. We do try to get patients up. We'll hear a little more about this from our physical therapy colleagues. We try to get patients up the first day if possible, especially folks we've operated on in the morning. Get them out of bed and moving. I tell patients they're in the hospital, but they're not sick. You're here for a procedure. The quickest way to recover is to get up and get moving. It helps all bodily functions to get up and get moving, and you avoid complications and problems. There's a lot of different ways into the hip. This slide demonstrates that we can get into the hip through essentially 5 different approaches. And if you go to a meeting of hip replacement specialists, everyone has their favorite. That tells you that there's no perfect solution there. If there was a perfect solution, we would all do it the same way. Each of these has advantages and each of them has disadvantages. Fortunately, nowadays, the way they're done, you can have it done through any one of these approaches, and a few months later, if you quizzed people on the different approaches and lined them all up, they wouldn't be able to tell dramatic differences. There's some differences in terms of sort of the immediate early stage recovery, but really in the long run, the more important issue is not how you got in there, but how the components were placed and make sure that they're positioned properly and they're stable. There's a fair amount of press for a direct anterior approach, and I trained on that, and it has some advantages. It does have some distinct disadvantages, but it happens to be sort of the popular thing in the press recently. But having seen a lot of patients go through it, I do not choose to do that direct anterior approach just for weighing the risks and benefits and what I think are best for my patients. But it's a perfectly reasonable approach for other surgeons who prefer that. The bottom line is, in my opinion, you should pick your surgeon, not your approach, because you want the surgeon to do what's best, what they think is best for you and what they're most comfortable with. And I can tell you the results really don't change dramatically from person to person with these different approaches, as long as it's done well. There are potential problems and issues. Fortunately, we minimize these, but you have to know going into surgery, everyone asks what can go wrong. And the nice thing about what we do as compared to other specialties is that they're rare. The complications are very rare. And we are very aggressive about trying to prevent complications. We're very aggressive with our, for example, the DVT prophylaxis, trying to prevent blood clots. We put you on a fairly potent medicine the day after surgery so you don't develop blood clots, and it really reduces the incidence of blood clots. Other things like infections, the beauty of working in a hospital like this in terms of infection is that it's not a teaching hospital. There's very few people in the room, and the biggest cause of infection they've found through studies is the traffic in the operating room. So if you're at a teaching hospital where all of us trained, you know that there's a resident, there's an intern, there's a fellow, there's an anesthesiologist, there's a resident anesthesiologist. There's literally can be 10 people in the room at any given time, and people come and go. And that traffic is what creates problems as far as infection. Here, it's not a teaching institution. We have a very good, tight team of people that are in the operating room, and there's none of that traffic that comes through. And so we have an incredibly low rate of infection is very, very rare. But we have to be diligent every day, every patient, to prevent that complication. So what to expect after you have your hip replacement? You become more attractive and you walk on the beach. Well, you can walk on the beach. It's a dramatic change in the quality of life when you have your hip replaced and when it needs to be replaced and everything goes well. And the gratifying thing about what we do is we see that every day. People come in and are so happy. For example, today the woman with hens brought me her 6 eggs that were hatched this morning. And it has nothing to do with me. It has to do with the fact that she has a new hip and she's walking around and she can get those eggs without any discomfort. So it is a life-changing event for many people, and it's fun to be part of that. We do a good job of it here. We have a good team, and you'll see some of the other team here. Our anesthesiologists, our nurses, our therapists. You've seen Tori, the leader of all of us, and we get people through this process in a very pleasant environment, a very pleasant way. And it's not easy when you're going into it, but when you come out on the other side, you realize that it was a great experience. So good luck, and we'll be happy to answer your questions.